people come to the pain clinic. I think oftentimes when people hear clinic, they think of like a freestanding, I go to here for my pain clinic appointment, and then I go here to the hospital. But it's actually physically inside the hospital. What is the pain clinic? How is it best described as far as being a part of children's?
Okay. So I would say that the pain clinic best fits with the children's kind of model in that most people visit their primary care provider and they visit the doctor because they have some sort of pain issue, be it because of some acute illness or because some sort of other process that's going on chronically. But we work with the rest of the team members in the whole clinic to basically provide the best pain-reducing care possible. And within our clinic specifically, we generally work with the kids who, quote-unquote, aren't getting better, whose pain isn't being reduced with the general acute care management of pain, and they end up coming to us as a specialty clinic or being referred out by their other providers.
Mm-hmm. So a lot of times we'll see kids who have been seen by other subspecialists, so neurologists, rheumatology, orthopedics, things like that, for whatever pain condition there is. And either that treatment doesn't work enough or they're told that that specialty can't help them as much, and then they get sent to us. And usually we see kids whose pain is there for some reason that's not based on a tissue or an organ. So we get a lot of people sent to us from different clinics within children's as well.
Do you know roughly how many patients we see annually?
So that number's changed a lot. This year we probably will see about 120 new patients a year.
Geographically, what do we pull from population-wise? Is it kids exclusively from Minnesota and Wisconsin? Do we get travel from all over the U.S.? Are we seeing people from international areas?
The large majority of our patient population we see here specifically in clinic do come from the area, within an hour drive. But we do have kids who come in out of state, who come in from way up north, who come in from across the country for a initial visit and then get recommendations and get closer care or care closer to home. And we kind of will manage their care over the phone or via email, but most of our patients are local.
Or coordinating with their therapist closer to home.
What has the experience been like since moving into this space?
My biggest thing is that I was consulted through rehab, and so patients would come to see me over in rehab with a completely different feel and a bunch of different therapists there, and then they'd have to schlep themselves way over here and they'd get different treatments, and it was just so compartmentalized, and it wasn't really we're all in this together kind of feel. And it was such, in our last other space also was more industrial feel. It was an office building. It was just pretty standard. And so having us all together in this new beautiful space, and especially this healing environment where everything's kind of relaxed and very spa-like, it kind of sets the tone for the kind of interdisciplinary treatment that we have, that we're all in this together.
Yeah, I think people like that we are able to talk more and they see us talking. I think it's much easier to collaborate when we're all in the physical space together. So sometimes we can pop into each other's appointments if we need to make sure they are getting that interdisciplinary care. A lot of times our kids have seen lots of specialists before they come see us. It's not uncommon for them to have seen 3 to 5 specialists before they see us. So it's also really nice that our clinic is so different than what they expect a medical clinic to be like.
And oftentimes, a lot of the patients that we see, they're specialists, and multiple different providers don't necessarily have the means to communicate effectively or as smoothly as possible. But since we're all in the same exact department across the hallway from each other, that we can collaborate and say, so-and-so is here today, and this is their symptoms they're going through, or this is the new stressor in their life. Here's how we can modify today's treatment in psychology, or modify today's treatment in family therapy or physical therapy or their medical provider appointment. So they'll be all on the same day, hopefully. We try to coordinate that so that we can adapt care on the fly.
What are the members made up of?
So generally our pain clinic team of patient would come and visit us with their family, and we would have myself, a physical therapist, psychologist, social worker who also does a lot of our family work, and a medical care specialist, be it a pediatrician or a nurse practitioner. And so we all meet with the family together in one room and go through their history and their story, and we see where they've come from and where they want to go. and then we each do our individual assessments, and then we follow up with clinic afterwards with each of us as a discipline.
I was curious about the age range also of your patients and who you would consider being eligible for care here at the clinic.
So we have a pretty big range. I think our youngest patient right now is 5 and our oldest is probably 18 or 19. Usually we see kids who have had some sort of pain condition for a few months and then also pain to the point where it's interfering with function. So the pain that's making it hard for them to be a kid. So whether it's going to school, playing their sport, seeing their friends, sleeping normally, or maybe all of those.
Our typical age group is around 12 to 15, 16. That's kind of like the bread and butter of the pain clinic.
And am I in the right direction when I say pain can lead to other pain? Maybe living with pain for a certain amount of time can lead to pain that increases that wouldn't have existed if not for experiencing that initial pain?
Yeah, and that's kind of the bread and butter story of the pain clinic, is that a patient will come in with one simple diagnosis, be it they had a concussion or they had an ankle sprain. Well, not that a concussion is a simple diagnosis. Or the flu, and they get like the stomach ache from the flu, for example. And then suddenly weeks go by and there's other symptoms resolved, but they still have abdominal pain. And then they start missing school, and then they start getting weak, and then they start getting headaches, and then they have back pain, and then it spreads, right? And so they have this like sensitization to other pains. And so then they go to specialist because now it's GI is involved. Okay, now neurology is involved. Okay, now orthopedics is involved. And so then everybody gives their 2 cents and really says, well, diagnostically, you're clear, and then we send you to the pain clinic.
Does it feel like a complicated puzzle sometimes when you do get patients? And is there ever a period of time where you're racking your brains trying to figure out, okay, how do we best treat this patient? Or do you usually have an idea based on the patient's prior experience with other specialists?
So I think one thing that's kind of nice is that when we see people, usually by the time they get to us, they've seen lots of specialists, they've had lots of testing, and things have been ruled out. And so what we know then is once all the dangerous things have been ruled out, all the tissues are fine, all the organs are fine, we know that their pain is caused more by their nervous system and central processing, and that oversensitivity of the nervous system sending too much of a pain signal and then their brain not being able to regulate it. So we actually can help explain the mechanism for pain for families. And like you had said, is that pain can cause more pain, and that's kind of what we feel like happens, and that's what the research is showing happens, is that our pain that we have in our body is usually a warning sign. It's usually something telling our brain that there's some danger, there's something that we need to do and we need to stop. And so what we do then as humans is we listen to our body, we stop doing whatever we're doing because that's what we're kind of pre-programmed to, and then that's also what other people tell us. If it hurts, don't do it. And so when we see people, what we usually have to do is kind of rehab them back into their life. And by rehabbing them back in, we're able to help them overcome their pain. So just kind of working together to help them kind of go back into their life, which is actually what really helps their body overall work better. We don't really have a name for the diagnosis besides chronic pain, which is kind of a misnomer. We don't expect it to be chronic going forward. We actually expect it to end and that they can overcome it, which is a little different than the adult population.
And it's kind of interesting to have explain the rehab approach to families, like you were saying about, is it kind of hard to kind of piece all this puzzle together? And so sometimes it'll surprise families when we say, yeah, you saw a rheumatologist, you saw a neurologist, you saw orthopedics, you saw GI, you saw everybody, you saw your primary 1,500 times. And then we go, oh, that's easy. All you need to do is normalize your life. And because we've seen hundreds of kids every year that have been through every single subspecialist, and it's kind of nice to get the clear medical, we get the go-ahead from a medical standpoint, because they're safe to move. Sometimes just that reassurance, and that's kind of the biggest thing we do with these kids, is reassure them that they are safe medically, that they can progressively normalize their life, that we can get them slowly back to their goals. The number one priority for our clinic is to just explain what pain is, as an output from the brain. And so then these patients are like, oh, I can have pain in my stomach without there being something wrong with my stomach. I can have a headache without there being something wrong with my head specifically, right? We always tell our patients, if you didn't have a brain, you wouldn't have pain, right? And that's kind of silly to some of them, but it's true. So if a patient comes in and sees me and they had a bad day, and they're like, well, it's because I, went for that walk and now my feet hurt. Well, was it a walk that was different than your normal walks? No. Well, what else is going on in your life? Well, why does that matter? Well, okay, my best friend moved away. Oh, yeah, that could contribute. Oh, I didn't get a good night's sleep. Oh, that could contribute. Just teaching them those little piecemeal puzzle pieces that contribute to that kind of pain story.
Are there things that are being asked for parents and families to do in addition to the patient's rehabilitation, things that they can do to make that journey a little easier?
Yeah, and I think that's why we have a social worker who kind of does family therapy work. And that's, I think, one of our biggest assets to our clinics that a lot of pain clinics don't have. It's a hard shift for everybody to make. It's a really hard thing for parents to see their kid being in pain and not being able to protect them from the pain. Just like kids have that natural instinct of if it hurts, don't do it. Parents have a stronger instinct. My kid's in pain. Why am I going to make them do the thing that causes their pain? So we have a family therapist who works with parents to really help them understand why we have our recommendations, why our recommendations are based in science and how they work. Some of it's support, some of it's re-education, kind of following through with what the medical person has already explained, but just helping reinforce it. The other parts is, most kids want to live their life again, but they haven't in so long. It hurts too much too, and they're scared too. So really working with the families to help be goal set and help them with those behavioral goals so they're successful. There's a lot of negotiating, a lot of communication things, and helping parents know that they're doing the right thing.
Is there anything else that makes pain psychology unique as a form of treatment compared to any other form of psychology?
So I think most psychologists have the skills to do pain psychology work. Cognitive behavioral intervention is what is research supported to work with patients who have pain, and all that means is we help people learn about their thinking patterns, help them change their thinking patterns from thinking like, I always have this pain, nothing will ever help, to showing them that they can learn how to manage their pain on their own. Also, we teach the relaxation strategies. We teach them deep breathing, guided imagery, self-hypnosis if they're interested. We have biofeedback, which is a cool computer game that lets them see how their body responds to things. So I think what's different about pain psychology is that since I work in a pain clinic, I see pain all the time. And I know that this pain is real, that it's biologically based, that it's not a symptom of anxiety or depression. Anxiety and depression might make it worse, but it's kind of separate than that. And I think the other thing is I have biofeedback equipment, which is really cool. We've talked a little bit about how the pain that we usually see at this point causes nervous system activation. So their nerves are hypersensitive. They're sending too much pain signal. What biofeedback lets them see is how relaxed or activated their nervous system is. So what do I do that makes my nervous system activate, work harder? What makes it calm down and relax? And so we can kind of show them that I don't think I've had one patient who wants to come in to pain clinic to learn how to deep breathe their way through pain. It sounds silly. It sounds like it's not going to work. And they probably have already tried it. And so what we get to do is let them see on the computer, hey, look, when you do deep breathing, there's no change physiologically. Your body hasn't gotten to a relaxation state yet. My job is to help you get to that relaxation state so they can see it. One of the things that people will often say to me when I say I work in a pain clinic, a common response is, oh, that must be so sad, kids in pain. And I think that's the pervading idea out there, that our clinic must be really sad. And, oh my gosh, how could a little kid or a teenager experience pain from such a young age? And it's great to be able to educate people that it's actually an amazing clinic because we help them overcome their pain. That if we can catch kids and teens when they're growing up and they have these pain concerns, we can actually teach them how to overcome these pains, help them be back to their functioning, help them get back into living their life, and teach them strategies they can take with them forever.
It's almost like we should call it the pain ending clinic or something like that.
Yeah, I mean, that's one of the biggest one of the biggest misnomers is we call it a chronic pain clinic because that's who we see, but that's not our end outcome.
Yeah.
I think it's great for people to be able to have podcasts like this so they can hear about it, that chronic pain doesn't have to be there forever, especially for kids.
And I think oftentimes that the adult pain world seeps into the pediatric pain world, where you hear these stories of people who have pain their whole life, right? And oftentimes, even when I go to adult-related pain conferences or pain education sessions, they're like, the goal isn't to ever get rid of the pain because the assumption is that you're never going to get rid of pain. So it's unique from a pediatric perspective where I say, well, most of the people that follow through, the kids that follow through with our program, get pain-free or relatively pain-free. And that's not necessarily the model in the adult world.
What are some common misconceptions that patients have heard or anticipate hearing when they come in here?
So being a psychologist in a pain clinic is always interesting, and I think half the patients and families, maybe half the parents and almost all of the kids and teens are worried that because there's a psychologist and there's a social worker, it means that they're making up their pain, that it's, quote unquote, all in their head. Which I think can be things that they've misheard from other people when they've been told, your workup is negative, your body's healthy. So I think sometimes they misperceive that. And honestly, I think it's kind of funny because my response back is, well, that's great if a doctor's told you that. They know what they're talking about because everything is in your head, because everything is coming from your brain and your brain is in your head. So it's a really great thing for us to talk about. I like to bring humor into it because no one wants to see a psychologist for pain. I mean, no one does. We all want it to be a medical thing, and I like to show them that I am part of the medical clinic because pain is complex and there's emotional stress, things like that affect how our body works. And that's where biofeedback can come in too, so they can really see that.
What's the best way for people to reach you if they need the pain clinic?
I think our general intake number, 612-813-7888. That's our main line, and they can learn about our new patient referral process that way.
And I think on Children's website, we have some information and some videos about the clinic, the new space, and there's some contact information on there also.
Yep, and that's childrensmn.org. And then you can find the navigation at the top of the page. Easy to find the pain clinic from there. Dr. Desai, Andrew, thank you very much.
Thank you.
Thank you.